So to join the conversation, you may raise your hand or enter your thoughts and questions into the chat. The format is intended to promote an interactive conversation. So for those of you who aren't familiar with MHCC, MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned value-based care and to harness the potential of data in facilitating meaningful change. So this slide outlines important information about CME credits and disclosures. Following the event, you'll receive an email that contains a link to a questionnaire. The questionnaire requests feedback on the symposium and an application for CME or continuing education credit. We'd like for you to give your feedback even if you're not applying for CME or CEUs. And the planners and reviewers for this activity have reported no relevant financial information to disclose. So today's learning objectives. We're going to be learning why a digital front door is important to improve patient access, engagement, and overall experience. We're going to be learning how telehealth plays a role in improving accessibility and convenience, reducing costs, and better management of chronic conditions. And you're going to receive actionable tips to optimize the use of patient portals to facilitate convenient and secure access to health information, enhance patient-provider communication, and improve overall patient engagement. So here's our agenda for today. So we're going to have an overview of some select MHCC practice transformation activities. And then we'll have two subject matter experts, Alex Nason and Christina Proffenberger from Frederick Health, who will discuss their perspectives on our main topic. So right now I'm going to invite Gene Ransom, the CEO of MedChi, to provide some opening remarks.
So MedChi has been so happy to partner on these Learning Network series. And on a good news front, Melanie has assured me that we're going to keep doing these once we get through into the new fiscal year in July. So that's great news. We've actually been doing these since 2019, and the Maryland Healthcare Commission should really be thanked for the great work and the education they're putting out. I would just suggest to folks that they might want to consider going on the website, and a lot of the past meetings are recorded and up on the Maryland Healthcare Commission website under the Learning Network, and you can see some of the prior ones if you've missed this. Now today, I'm really excited to hear what Alex and Christina have to say about telehealth and how it's changed things. It's so funny how things have changed so much since COVID. And one of the positives out of COVID was we really sped up the adoption of this technology, and now it's expected. It's expected in everything we do. In fact, we're on Zoom right now, which would not have been the case 10 or 15 years ago. We'd be in some room somewhere and there'd be a lot less of us. But we're getting to hear from two really talented experts from Frederick, and I'm sitting in Annapolis right now, and I'm going to hear from them and be able to go to my next meeting at 1 o'clock right on time. It's really impressive, and I think it's something we should think about, how much things have changed and how much it's changed the way we do things just generally, but how it's going to change our practices. So I'll stop talking and let the subject experts go forward. But MedChi it does provide the CME, so if anybody has any issues with the CME, please let us know. And I just want to thank Melanie for all her hard work and the Maryland Healthcare Commission for a terrific program. And without further ado, I guess we'll turn it over to you, Melanie, to introduce Alex.
Yeah, thank you so much. So I have lost my PowerPoint temporarily. My Microsoft went down, but I am going to just talk through some practice transformation activities quickly with people before we turn it over to the subject matter experts. So MHCC has been part of practice transformation for over a decade. Our first program was the Maryland Multi-Payer PCMH program, which ran from 2011 to 2016. We then partnered with MedChi, the University of Maryland School of Medicine, and the New Jersey Innovation Institute to complete activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019, which was a federal initiative that included over 124,000 clinicians. We've contributed to planning and policy development for the Maryland Primary Care Program as well. So in June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. They've been working with practices to collect, analyze, and utilize patient data in a way that enhances efficiency and patient care. There's tailored coaching, workflow redesign support, and training, and it ensures the practices have the knowledge needed to drive meaningful change. Approximately 87 practices completed milestones to date, and the program does end on June 30th, which is Monday. So as most of you know, the MHCC convenes peer learning network events like this one in collaboration with local and national healthcare leaders on topics such as health equity, advanced care delivery, and practice transformation. And those are all listed on the MHC website. We have the historical recordings and slides for people to review. And we're very excited that for 2025, we are launching a new initiative called Beyond the Textbook, Real World Medicine and Case Studies. And these are 10 to 30-minute pre-recorded on-demand sessions that really take a deep dive into some topics that we are all on this call working on. So I think you guys are going to be really excited when you see some of these recordings, and we will be launching that in the near future. So with all that, I'm going to turn it over to Alex and Christina to walk us through some digital strategies.
Thank you so much for giving us the opportunity to share a little bit about our journey into sort of this digital front door, this digital experience when it comes to supporting and improving access for our patients and our consumers in our community. Quick introduction, my name is Alex Nason. I'm the Director of IT Innovation here at Frederick Health. Been here for about 8 years now, focusing on all things sort of digital for the health system. If you're not familiar with Frederick Health, independent, one of, I think, less than 200 left in the country, health systems, largest geographic county in the state of Maryland, and also one of the, if not the fastest growing county in the state of Maryland. So I'll also turn over to Christina to have her a chance to introduce herself.
Hi, I'm Christina Poffenberger. I have been in healthcare for 27 years now and been with Frederick Health for 19. I have had several different positions here, starting in primary care, and then I was a trainer with our revenue cycle. And then for 6 years, I was an actual practice transformation specialist, and now I am the practice manager for our otolaryngology office and audiology office here at Frederick Health.
Great, thanks, Christina. So together we'll share a little bit about our experiences and sort of how we've navigated the digital front door for our health system. We've talked a little about objectives already, so hopefully, at the end of the day, I hope you guys learn a couple things. But really for us, it's about really understanding what is a digital front door, how it relates to health systems, some of our lessons from telehealth, as well as our lessons from a search to schedule journey for our patients. And also mention a little bit about the patient portal and its impact. But I don't want today's presentation to be something that's intended to be a path that your organization should take. Every organization is unique. Every organization has their quirks about them. And so what might work for us in our community might not necessarily work for your patient population. So I think it's important to pick out those insights that you can apply to your environment today. So the digital front door story for us started about 8 years ago. We were starting to really frame out and lay out what an experience would be for our patients as they came in to interact with our organization. And early on, I think for us, we looked at things in a way of being transaction ready. Right. So helping patients interact with us, with our health system in a bunch of different specific ways. And in the early days, and I think even today, we continue to work on that as a strategy. These are all still separate individual pieces, but we're trying to roll them into a single sort of digital front door experience. So, well, we might have a ratings and review in one space, we might have scheduling, we might have telemedicine, and we have all these things individually. Really what we also focus on is trying to make this into a single front door for patients and consumers to interact with for us. And so much of this also changed with COVID too, right? Because with COVID, before COVID, I think these were all nice to haves and things that we were all looking for. During COVID, many of these solutions became things that we sort of kind of had to have for lots of reasons. We also think about our consumer access and engagement in sort of a couple different big buckets. One is around acquisition and growth, right? So how do we help how do we help patients and consumers find us and engage with us and learn about us, and how do we bring them into our health system? The second one I would say is around the experience, the ongoing engagement around keeping people engaged with us clinically, operationally. How do we help them interact with us to help make their experience go that much smoother? So whether we're talking about pre-registration or check-in using digital solutions, whether we're talking about integrating transportation and coordinating transportation for patients, and using a digital solution for that to make sure that patients are coming to their appointments. And then follow the last stage we look at it is our enduring relationships. Those things that how we keep the ongoing relationship happening for our patients, and how do we ensure that they are staying connected with us along the way. Our patient, and those are with regards to our patient portal, personal health records, a CRM system, online bill pay. Those tools sort of post clinical event. And for us, the digital experience also is looking at along the digitization of this experience is also looking at along the consumer journey, right? So helping those patients discover and learn about us. That's sort of those early phases, right? During the search and matching up to being an appropriate patient for those providers. How do we best help those patients navigate our organization, right? So using tools like an AI chatbot to help with that. Then we get into sort of the transaction piece that I was mentioning earlier around online scheduling, online registration, doing those tasks that maybe in the past were done in a more analog kind of way, pick up the phone and calling, or filling out some paper. Now we're working towards making much of those things digital to make it a little bit easier for the patient, easier for the staff, and a little bit smoother. And then post-wise, the engagement, right? How do we stay on top of your appointments? How do we have a clinical engagement, the portal, et cetera. And for us, we also look at this in a couple different ways of how does an organization get there. So it really started for understanding and assessing where you are currently, understanding what the bottlenecks are, what the challenges are. One of the things that we kind of lay this out is try to help us not to just chase the shiny objects. Leaders and executives do enjoy looking at technology and really want to bring those things in, but it's really, really imperative to make sure that we're doing things that we believe can support our challenges and the pieces and the challenges along the way that we were having. Adopting those things. So once we've assessed and evaluated where our bottlenecks are, now let's look for some solutions to help us plug those in. How do we then optimize that, right? How do we ensure that once we've adopted and implemented those pieces, how do we continue to look at it and improve it? We're never done once we implement. We're always looking to continue to optimize and integrate that into our systems. And then expand, right? So once we've done one piece of this, how do we expand it to include other elements to this? An example that we are just early on, I'll just mention it today, is we're moving to a new appointment reminder system. So that is a traditional appointment reminder texting alerts that you're all familiar with. Now we're starting to expand that into the next phase of that, which will allow for some wait list management system. So for patients to book appointments. So we're starting to expand that beyond just what is the typical thing that we first started to get up and running. And another piece of this, kind of final to talk about our why we do this in our looking at the digital front door and what brings us here, is that we often talk about sort of meeting the patient where they are. Whether we're trying to meet the patient where they are as they're searching for symptoms online, whether they're trying to search for a provider, we want to be able to provide it in a way that that is best convenient for them. I'm not saying that everyone is convenient. It's convenient for everyone to be online. I'm not suggesting that it's the only way is for to understand or learn about providers should be through online web, because some patients really would like to look at a piece of paper and review and learn and maybe review a provider's bio that way. But what we want to do is we want to make something, we want to consider and keep in mind what is in the consumer's journey and what they're thinking about along the way here. In 2023, I believe it was, we actually at the organization started a consumerism committee to discuss the digital approach to that. And so we meet regularly. We meet once a month. It's a combination of executive leaders from hospital leadership, ambulatory leadership. We're talking about folks on the clinical side, patient service, patient service excellence, all the way to folks that oversee scheduling as well. So it's a really broad, comprehensive group that really comes on board to really talk about the patient journey and understand that lots of different parts of it impact the entire patient journey. I'll pause here for a quick second. If anyone's got any questions, I don't have the chat box up and running, but if there are any questions, happy to talk about the general patient journey as a whole at this time. For anybody?
I have the chat open. I don't see anything right at the moment.
Okay, great. So I'll just sort of pivot into our kind of our first section here and talk about our telehealth experience. I must say that this conversation was very, very different pre-COVID. This is something that I've been involved with on the telemedicine side. Well, at Frederick Health, 2018, but before that, going back to 2002 when I was at Johns Hopkins during a period of time. In fact, I spent a lot of time with Dave Sharp and the MHCC back in 2008, 2009, 2010, as we were all trying to sort of put our arms around this thing called telehealth. It's a very interesting place to be here now. I never wanted a pandemic to be the thing that sort of got us to the next level, but I kind of had a feeling that it was going to be a pandemic to put us at the next level. And you can see here from this slide that this is two components of where we are with our digital front door, both synchronous and asynchronous experiences for telehealth. I think 5 years ago, 6 years ago, I had to have this slide up. These days I don't think as much, right? So, but I will just say, as we're talking about telehealth, we're really talking about telehealth, telemedicine, virtual care. It all blends together. And at this point, I think we're all very comfortable with it, as far as understanding sort of what it is and how is it executed. I still think we're evolving with our technologies. I still think we're evolving in where we're going to go with it. But as we are today, I think we understand kind of that definition of telehealth. One thing that's important when we think about telehealth too, it is very broad, right? So, texting patients, sending emails, telephone calls, using technology to track pacemakers through the home system that gets transmitted back to the doctor. Right, so radiology, dermatology, pathology, those abilities to send images across. As you kind of move up the spectrum, things get to be a little bit more complex. A lot of what we do in our day-to-day practices is that middle green one, which is telepresence, right? There's e-visits and specialty consults. Remote patient monitoring. We have a very extensive remote patient home monitoring program at Frederick Health, almost 325 patients being monitored regularly by a team of nurses. We're also an EICU program, much, much more complex as we start to think about those clinical tools that we use to transmit information back to the hub, so to speak. And then even the work that I did when I was at Johns Hopkins for a period of time, we dabbled in the telesurgery concepts. And again, when I say this, I'm talking about 2000 to 2013. So the technology has really changed a lot. But back then we were thinking about telesurgery, both for guidance, support. Telementoring is actually something that I did a lot of work where our providers would actually watch live surgeries happening elsewhere and give some support and guidance to a specialist that might just want to have another set of eyes to watch something. Regardless of how what you do, you'll see sort of the technology gets to be a little bit more complex as you move along the spectrum, as well as the workflow, ensuring that things are flowing properly as well. It gets to be a little bit higher and takes a little bit more resource there. I think this really should resonate with a lot of you probably today, having gone through the pandemic. I think in the past, I think it was very much thought about telemedicine are a bunch of physicians and some cameras and some patients that are all, and that's all you see. And it's a patient talking to a physician and on camera, and that's fine. And how hard can it be? But I really think it's important to note, and I think we're all learning this, that, physician scheduling, coordination of that, clinical documentation, particularly for billing purposes, is really complex. Offering IT support, depending on the kind of service you're talking about, this has to be maybe 24/7. For example, if you're doing something in the stroke space, a call center management, calls coming in, and coordination of care to a physician who's available to pick up that. Physician licensing and privileging, a lot of that was waived during the pandemic. It's now back. So a lot of complexities in ensuring that physicians are licensed where the patient is. And I think also we're talking about trying to figure out where we want to go with EMR integration, right? So how do these telehealth consults get integrated into your medical record system so that there is that continuity of care? So I think for me, this is something that I think our organization really learned the hard way. I would say when we went from so few to so many telehealth consults. And also one thing, in the early days of the telehealth programs, Maryland was one of the 4 leading states when it came to having a good parity law around telehealth and providing coverage that way. I think the work done by the team of us that were really passionate about this and thought that there was a strong future for telehealth, really tried to get out in front of this. I think early on it became, well, it's all about payment and reimbursement. And by the way, it is all about payment and reimbursement. But I think really good policy gets into helping with some of the definitions of telehealth, being clear about what it is and what it's not, understand what that provider-patient relationship is and helping define that. There's some interesting, in the early days, there was some interesting, we didn't have a lot of detail in some of the policy out there. So there was a lot of opportunity for interpretation, and we sort of worked to help clean that up a little bit. And throughout, whatever your definition is, whatever your patient-provider relationship is, where we're talking about payment parity, whatever the technology is, right? Telehealth has never really been about technology. If you're going to talk to a telehealth person like myself, we'll never talk about, camera or Zoom capability or some of those technical things. What we will talk about is meeting the standard of care and ensuring that patients are being treated and can be treated via telemedicine as they would be in person. And if they can't meet that standard of care, then I think we have an opportunity. I think that's something where telehealth does not fit really well there. I see a chat message. Yeah, so some of the triage process. I'm going to get into that as well when we talk specifically about our programs. The question was around our triage process and what happens if a patient has acute psych conditions and how to connect with them 24/7. I will talk a little about that as we further our conversation. Oh, here we go. Some of the telehealth, pros and cons, I kind of turned them into advantages and disadvantages. I think some of the advantages of telehealth, right? So increased accessibility. I think they can become an opportunity for become more efficiency in the practice schedule. We have opportunities for reduced hospital admissions, keeping those patients either at home, or if let's say they're in a post-acute care facility, keeping them there to give them some of that support locally instead of moving them into the hospital for something that could have been treated locally there. Cost effectiveness. I say cost effectiveness, but I think the MBA people will have their different questions around what that means. When I think of cost effectiveness, I think that it can be more of efficiency of the process, particularly if there's clinical information that's captured ahead. Also, avoiding waiting rooms, the physical space of those waiting rooms. Also, and also telehealth can play a big role in supporting value-based care, which is really important here in the state of Maryland. There are worries. I don't think they're cons, but I do think there are worries and concerns. So technical barriers, ensuring that the technology is there to support what you're trying to do. The platform infrastructure costs, always a big piece about trying to figure out what is the investment needed to make this happen. Privacy concerns, not just HIPAA, but also cyber privacy. Again, making sure that we're taking those same steps, not just in a technical component, but also in the delivery of that care, right? You don't want to be doing telehealth visits at Starbucks out in a public space where people can hear the conversation or see the conversation happening. And also, I think for us, I think some people were concerned that this was going to encourage more visits and overuse of services. And I think we found that maybe early on we were finding a little bit of that, but I think now people are more comfortable with understanding sort of where it's appropriate and where it's not appropriate. The final one of fragmented and siloed care, that is actually something that is important to really bring up here. As patients are starting to seek care elsewhere, ensuring that those results or that information comes back into your primary care health system, I think is a really important one. One of the nice things of some of the services we offer within Frederick Health is that if you're part of the Frederick Health primary care community, for example, and you get an urgent care visit through us, it's our doctors doing that, and it connects to your patient record here. So there is that continuity of care versus if you went to a third-party location there. And also, I think it's important to know that not all patients are benefiting from telehealth. Over 400,000 Marylanders, I picked this, saw this recently, lack access to high-speed internet. So in order to ensure that we have good coverage, we can provide these services, we really want to find ways to improve telehealth access. And so whether that's providing access to devices, helping patients obtain some access, notifying patients of ways to subsidize some of the broadband access to care, some of the digital literacy. These are some of the things that along the way of telehealth kind of comes in parallel to just delivering that care. Before I jump into a little bit of our programs, let me pull up the chat again. So the comment here around blending in-person visits with virtual is a challenge. It absolutely is a challenge. And in fact, I'll bring up I'll talk about some of how our programs here, and then when I turn that over to Christina, she can talk about some of those specifics in the day-to-day operations of these practices as well. And yes, that idea of that some patients think that this is all for free, and managing that where it's absolutely not. It's part of that continuum of care. So I'll talk about some of our programs here at Frederick Health and what we've done in the telehealth space for a bit now. So our medical group has been doing telehealth for a number of years. Of course, the pandemic took it to a whole new level for us. These are scheduled ambulatory visits. They are coordinated. They're on the provider's schedule as a telehealth visit. Our providers have the option to use 3 solutions for telehealth. The majority use 1, but providers must use one of the approved solutions for video. and when I say approved solutions, it's really ensuring that these networks and these systems are HIPAA compliant, ensuring that they are stable networks. We want to ensure that providers understand that doing a FaceTime is just not appropriate. And while the messages around using a WhatsApp might say that they are secure, that information is still going someplace. And so that's why, for our perspective, it's really important to use a solution that has been vetted and approved by the health system to ensure that we understand where any data could be possibly going to, and ensuring that it remains private and secure, and in an appropriate place. All clinical documentation is is completed in the EMR, so everything is documented there. It's billed in a particular way, and these are all encountered and billed to third-party payers. As I said, we were doing a dabbling here and there pre-pandemic. We then went up to 100% for a little bit of time, and now we're working our way down. And we do about 5%, I think, of our visits are telehealth, but that's a pretty big number for us. You'll see here right now, so we actually have an 11% increase over this time last year. So about 12,000, almost 13,000 visits a year is done via telehealth. So again, not a huge number for us, but one that is impactful, and I think we're finding that patients are looking for it when appropriate. We also noted that the majority of our cases are also attributed to a primary care visit, which to me sounds, which is the most appropriate, I believe, type of visit there. Christina, do you want to jump in on any comments or experiences that from the ambulatory side on this?
Yeah, so like you had said, I mean, pre-pandemic, from the ambulatory side of it, we really didn't have a whole lot of scheduled telehealth visits. And then once the pandemic hit, I was one of the ones that was like working with the physicians, the medical offices, to really try to figure out how we could get our patients on through telehealth. So that was building those appointment types. And, during the pandemic, we had several different appointment types. Post-pandemic, we've scaled it back a little bit more. And now we actually have, some carve outs. The specialty offices versus primary care is a little different. Speaking from my specialty office, we need to really see the patients and look in their throat and their ears and things like that. So we don't see that many. And even during the pandemic, we didn't really see the high volume that primary care did. But from a primary care provider schedule, we actually now have carved out spots closer to the end of each provider's day that are telehealth. That way, the goal for that is when the patient is checking out from seeing their provider and they're making that follow-up appointment, maybe it's a 3 or 6 month follow-up for meds. They give them the patient the option, would you like that to be a telehealth visit? So then we fill the schedule up with some of our telehealths. If for whatever reason the telehealth slots don't get filled, we do have like a release on those, so that way we can see in telehealth or in-person patients. But pandemic, post-pandemic, a lot of things have changed, and we've learned a lot from the telehealth visits, and we feel like, or I've also seen that our patients really like to have the option of in-person or telehealth.
Thanks, Christina. Yeah, I think that's another important part, is that telehealth is not for everything, and it's not for everybody. Patients want, if appropriate, patients would like to have the option. I think there are definitely some clinical specialties that might be more of a, I'll use the word data review, meaning let's look at your lab results together. Let's discuss kind of how you're feeling, less of that physical review there. So I think it's an important. So I think again, it's important to note that telehealth is not for everything or every type of of care or condition. There was a question earlier about, a patient having acute, psychiatric medical condition. And again, we try our best to ensure that if something was to come through telehealth in that way, that we are able to direct them or redirect them to an appropriate level of care that way. And I think a lot of what telehealth has been able to do, or what we've done because of the pandemic and now, is also educate patients on what is appropriate use of telehealth, and where does it fit in well and where doesn't it fit in well. Going back earlier, there's also another comment in the chat there about the scheduling, and I think Christina just validated that, right? Coordinating the schedule, having that blended schedule can be a challenge. I've seen organizations where they've actually set a provider off to the side for half a day or for a chunk of time for them to handle telehealth visits and coordinate it that way. But there's been an interesting combination of blending of a schedule that is becoming a challenge to ensure that the schedule is optimized appropriately. Again, I showed some data about our growth in our ambulatory sites here. You could sort of see that the orange is ahead every month there. I will point out, you all may have heard, but back in February, we actually had a cyber event, so we were down offline. So a lot of our activities that were typically documented within our EMR was offline during that period of time, and so that's why we have this significant jump here. But we have been trending in a very positive way of increasing this. And again, we want to increase it not because we're trying to shift patients or treat patients any differently, but really trying to help drive that access and meet that access needs. Second program we have up and running, different than our primary care or different than our ambulatory care visits, is our urgent care telehealth service. This urgent care solution is supported and staffed by our urgent care providers. It's targeting these low acuity conditions. So we got a lot of rashes, pink eyes, UTIs, upper respiratory infection type situations, things that people typically walk into urgent care for. We offer both services asynchronously as well as synchronous platform. Asynchronous, meaning a patient fills out a very, very comprehensive, I use the word questionnaire, but it's more than that, because as patients are answering questions, it's taking you down. It's almost like it's a sophisticated interview process, and that data is all collected and then presented to our provider. We also do synchronous visits as well. Synchronous meaning live video as well with our providers. We use a platform called Fabric Health. We've been using them since 2018. And really, we started this pre-pandemic around high utilization periods of flu and cold season. Boy, that was simpler times back then. We do not currently bill third-party payers for this service. This is an out-of-pocket payment for patients to do this. And we've actually seen an interesting kind of evolution for us with this program. Since 2018, so over 10,000 patients have visited our site. That means they've arrived. That means they've started the process with us, but maybe they didn't go ahead and through the whole process or completion process. But of that, 60% do. So 6,000 have gone through, completed it, including the credit card payment, including putting in all that clinical information. I want to highlight here the 2,290 or so that the system itself, the platform we used itself, determined that based on how they were answering the questions, the system said, clinically, we don't think that this is appropriate for telehealth. And it actually kind of off ramps them and gives them a choice, shows them some options of coming into our urgent care facilities, encouraging them to call their primary care doctor, or other types of solutions there. So again, recognizing that not everything and not everything is appropriate for telehealth. What's also important, and this goes back to that standard of care that I mentioned earlier, that's so important to a good telehealth program, is Of those 6,000, 75% of them actually went full diagnosed through with our provider, meaning that they had enough clinical information to provide a diagnosis and treatment plan. 25% of the time, our provider says, I'm not really sure I have the whole picture here. I would really need to see some more information before I felt comfortable delivering a diagnosis and treatment plan. So therefore, they referred them out. So really, at the end of the day, there is still that judgment of the provider in delivering this care, which I think is a really important part of having this type of program. And while a patient might feel like, well, I don't know why you just don't give me an antibiotic, I think our providers and our clinicians really feel very strong about having that ability to really give their own personal judgment on what's appropriate. And stop that. And our chief complaint. Chief complaints here. I took out URI, upper respiratory infection, because those are by far a major reason of why people come and use this. But it's very broad for us. Skin conditions, eye conditions, burns, ear pain. Summer times here, we're going to get a lot of, I expect to see a lot of poison ivy as one. UTIs is another one that comes up quite frequently for us as well. Our growth has actually gone down in this space. I think for me, I think there's a couple reasons why. Number one, I think patients either forget about it. It's kind of, for us, it's maybe a seasonal thing where we're seeing a lot in the winter time. That's, I think, a major busy time for all this. So I think there's a seasonality to it that patients sometimes forget about it. So for us, we continue to do our marketing to get that out there. But I also think patients see other options. There's a lot of communications online. We're seeing a lot of ads on TV for these types of services. I think insurance companies are promoting what they offer as a benefit with that insurance company as well. Heck, even Amazon offers a urgent care visit, and these are some of the forces that we're up against as a health system with that competition, trying to improve that access. A couple final lessons learned broadly for telehealth. A lot of organizations rushed into implementing this. It's now time to sort of take that step back, review the process, see what works, see what doesn't work, and tweak it. Telehealth is not, and I don't think it'll ever be, the primary delivery care method of care. Patients have embraced telehealth as an option. As Christina mentioned a little bit, patients like knowing that if it's for something simple like a medication refill discussion, telehealth is there and they don't have to travel in to a location. It's a way to seek access. There is a lot of anxiety when it comes to our policies these days. A lot of folks are waiting to hear. It seems to be that Congress keeps kicking it down the road with regards to telehealth reimbursement. And as mentioned earlier, it's not for everybody. It's not for every condition or every type of consult. Christine, anything else you want to throw in about scheduling, reimbursement, provider experience on this as we wrap up telehealth?
Yeah, I was going to say that, obviously the telehealth impacts scheduling templates, as I had mentioned before, and making sure that we can get those appointments filled. It also could mean longer or shorter appointments, longer if there's technology, issues with the patients logging in. The other piece to that is making sure that we collect co-pays ahead of time, just like we would if the patients were to come in. It also is a risk of no-shows or, like I said, technical delays, and then the patients can't connect. During the pandemic, the reimbursement was broader. Post-pandemic, it's more limited and varies by payer and visit types, and making sure that we're seeing the patients with video versus just an audio. So some of those things have come up here recently that we really have to look into. Some of the providers were worried that the telehealth would be less for RVUs, but most of them are, you can bill them like a normal regular office visit as long as we are using that video capability and we can get that. And patients versus provider, patients love the access, really. for most part, the ones that want to, as a patient myself, I would love to be able to do telehealth for certain visits, but I also like certain visits to be in person. Some of the providers like it. It helps, with their like I said, with primary care where we have the schedules slotted for the end of the day for those providers, like two patients at the end of the day being telehealth, it kind of gives them some freedom. But it's also a balancing act between convenience and care quality.
Yeah, and that balancing act, I think, is the biggest challenge. And technology is going to change. I mean, I think over time we're going to find more and more abilities and capabilities that are out there. But it is finding that healthy balancing act. It's come a long way. It's definitely come a long way. And there's much more opportunity to grow in the technology. So I'll pivot now to a different aspect of our digital front door, the search to schedule. So this area here around identifying a provider directory, ensuring, helping that provider search capability and helping those consumers schedule an appointment. This was a journey we went on about 3, I think, years ago. Where we started this off, and for us, we really wanted to understand. It went back to sort of meeting the consumer where they are. So, excuse me, recognizing that, the data, the surveys out there show that patients really want to be able to use online scheduling to engage with their provider. They would, if there's an easier way that was more accessible to getting in for an appointment, patients would actually use that as a tool to switch. 43%, this is from a study, 43% of patients of appointments were scheduled after hours. I'll share our data here shortly. It aligns with that. We're also finding that as a broad study too, 64% of patients who book online are new patients, and I'll share our data that actually aligns to that as well. So it is a tool that people are looking for. I also think it's not. I think these solutions are also not just a young person's solution. I think we're finding that a broad use of the age demographics also support using these digital solutions. When we started looking at a consumer-driven scheduling tool, we knew we had a couple sort of points that we were looking for when we were looking to find a solution for us. So we wanted to be integrated into the workflow. We wanted to allow for new patient scheduling. We wanted to be at the network level, so we wanted to be able to cover a broad type of appointment type of scheduling. We wanted the patients to feel like they were still connecting with Frederick Health and not on a third-party platform. And we also want to show a consistent patient experience as much as possible. And for us, we also recognized in our program that we really needed to have something that was consumer friendly first in our searching capability. We wanted the data to be dynamic and easily updated. Providers are always changing their skills, getting new certifications, taking on new types of clinical spaces. We want to make sure that we were able to keep up with that and update that very easily and dynamically for us. We need the information to be patient friendly. What I mean by that is we didn't want to connect back to our credentialing database that had a passport photo from 1976 of the provider that was used for credentialing purposes as being that as the public facing image of this provider. So we wanted something that we could add sort of a patient friendly component to it. And we also had to be web and mobile friendly. We chopped this down into 2 small parts. The first part was around a partnership with our marketing team about building our provider profiles out, going through the clinical taxonomy of our providers, writing and promoting or I should say publishing a provider biography that was patient friendly so that patients could really get to know a provider when looking at that. And also an employee indicator highlighting those that were Frederick Health employed providers. But still, we are a partnership with our community providers, so we also have community providers on there as well. The second phase of this was working towards an integrated online scheduling capability, and that was working closely with the Frederick Health Medical Group, and Christina was pivotal in helping us do that. Just a few screenshots, and feel free to jump on our website and check it out yourself. But from our main page, we have our find a provider kind of tile there. From there, it gives you the find a provider capability. You can type in a provider's name. We can search by symptom or condition. We worked hard on clinical taxonomy to try to really help patients define things. So, for example, if a patient put in a knee injury or knee pain, then those providers around orthopedics would show up. Doesn't mean that the patients around family medicine don't show up, because providers in family medicine also deal with knee pain. But we would highlight our orthopedic providers here. Being part of a multi-specialty practice also makes this a bit more challenging than some other practices might find. But once a patient would click on a profile, they would open up that profile. They'd learn a little bit more about the provider. I don't have a screenshot of their expertise, but it outlines where they went to medical school. It outlines some of their board certifications. So it gives you sort of that clinical bio that patients are always looking to get to know the patient, know the provider a little bit better. So that was the first phase of this. Then we went into the click to schedule phase. And so now on our page for our primary care providers, you can now click a button and pull up a book appointment. It'll sort of give you a list. Are you a new patient? Is this for a sick visit? I think we have it as minor injury visit, minor injury or sick visit, I think we call it. Have you had an appointment with a provider in the last 3 years? This helps establish that relationship to knowing whether this should be a new patient or not. This data that you see on the screen pulls from our electronic medical record system, which is Meditech. So this is live real-time information that would come in. So the individual would pull this, the patient would select the date and time that works for them, complete the information with regards to first name, last name, date of birth, address, email address. We also, within this process, we also ask for a reason for visit as well. So some free text opportunity to see that information as well. In our workflow, we don't have insurance captured, but we have another way where we capture that on the back end there. But it gives you a chance to book it, review it, and then you're scheduled this way. You don't have to log into your portal, but it flows all the way back instantaneously into Meditech, and confirmation goes out from this system here. This has been a great success for us. And you might say, oh, well, why only 9% conversion rate? But we have over this past year, 8,700 sessions, 773 appointments were booked this way. That's a 9% conversion rate. Our vendor, Loyal Health, that does this, they see nationally about 7% conversion rate. Why? Patients search. They start their search, they look around, and then they drop off for lots of reasons. Some patients might want to just know what their options are available, but then they don't necessarily want to book at that moment in time. So that often happens. In fact, I had a conversation with a colleague who says, oh yeah, I just go on just to see what potential dates are available for booking an appointment. Again, you'll see the blank in February. That was because of our cyber event that happened here. After January 1st, we were live with all primary care providers. So we slowly ramped them up. And so now we're seeing, consistency of 130, 150 scheduled appointments during each month. I mentioned earlier, we're in line with some of the national averages. 59% of our patients, 59% of these 773 were new patients to the provider versus an existing one. So we're starting to see new patients using this a lot, which is fantastic. And I think from my perspective, the insight around when patients are booking is really important and helpful to us. So we're seeing patients that are doing this on Saturdays and Sundays, and we're also seeing patients that are doing this at midnight, at 1 a.m., at 3 a.m. When they're thinking about their healthcare. A few things here, and I guess as Christina and I sort of wrap up this session a little bit, specialty appointments are more complex. There's a lot of different one-off type appointment types. It's important for staff to be slotted into their correct type of appointment type. Insurance and referrals is so much more critical. Not more critical. Insurance is important to every provider practice, but the referral process is so important especially to a specialty practice. And they're also more complex in practices, right? So in the ortho space, some will do knees, some will do shoulders. So you want to make sure that the technology can support some of those intricacies and uniqueness there within a practice. Christine, anything else to comment on these complexities?
No, I mean, I would just say, as you had said, from like the ortho, and even from ENT, I mean, we have surgeons that see specific types of patients. So it's really, when we dive into getting the specialty offices up and running with direct booking, we really have to look at that and figure out how we can make that happen where the patients aren't just getting on a provider schedule and then we have to call and reschedule, because that defeats the whole purpose of direct booking.
Yep. One thing that's also interesting in the data that we've seen, or relating to the data, is that we have a third party contact center that manages our calls and does our scheduling for us. So every patient that we don't have to put through that call center is actually a reduction in cost for us at the organization. So that's been a nice return on that investment that helps. So some final lessons learned on this. For us, we started slowly. So at the beginning, we had 3 providers. Then we added on a few more. Then we added on a few more. And then after the first of the year, we had all 45 primary care providers up and running with online scheduling. We were very conservative and slow in our approach. You have to be, because I think a schedule is very sensitive and important to a provider. So managing that was important to us. Patient matching can be complicated, as Christina just alluded to, but patients love this ability. They love being able to just, with several clicks, being able to book that appointment. And I think the one thing that I've noticed is that patients think about their care 24/7, 365. So 3 o'clock in the morning, patients are booking this. It just doesn't matter. Saturdays, Sundays, they're just not thinking about between 8 and 5. One last thing on the patient portal. I only have one slide here, but for our patient portal, for us, it's really important around our scheduling. For us, it's sorry, not scheduling, to help our patients stay informed, engage in their healthcare decisions, and empower these patients to participate by seeing their care, tracking their care. Staying on top of those decision makings that has to happen through their healthcare process. We try to make our portal as friendly as possible. Interesting enough, again, we're seeing over 100,000 logins a month of our patients, and this is connecting to about 21,000 patients. So 21,000 unique individuals for 100,000 visits. So on average, about 4 or 5 times. Do I think it's a lot of those patients that are looking for maybe a lab result and they might log in once or twice? Yes. Or they might log in for their pre-appointment visit and then log in again to get that information for where is their appointment or their schedule or review a timing, et cetera. But our patient portal is a very active piece. We're actually going through a major upgrade as well. So it's been quite a interesting ride for us with our clinical portal here. But I think for us, we're actually I think we are number 2 in the country for Meditech users for activity within a portal. So for a small health system like ours, we actually have a lot of activity going on. There was a question about do we have a separate digital front door app that sits on top of Meditech portal? We do not. yet, although it's something that has been in conversation for a number of years now. We've actually explored a few standalone sort of an app for Frederick Health that would help connect sort of these pieces together. But that is sort of the next vision, I think, as we start to think about where do we want to go with this. It's a great point. So those are my final thoughts here, because I know we're at time. Digital is omni-channel. The future is, it's not just digital first. Patients will not just be treated virtually, but it's be all part of this blended approach to care. And many healthcare providers who went through this big bang are underestimating that the value is around the patient experience. So it's not about the technology. It really is about these experiences that we want to make better for folks. And then my last slide, which I like to take from an IT perspective, is that lots of things need to happen in order for technology to be delivered. And only one of them is picking the technology and implementing the technology. This really is around executive buy-in, champion buy-in, project design, success metrics, how to scale, the workflow, communications, training, and then growth. So there's so much to implementing technology, and that's a broad statement around everything, not just these digital solutions. So thank you. I know we are a few minutes over, but I'm happy to answer a question, or in the future, if Melanie wants to send it to Melanie, you can forward it to me, but thank you so much.
Yeah, if people send me the email questions, I'm happy to send them to you. And thank you to you and Christina. I think this was this is a really great presentation and gave us some different perspectives and some I know a lot of people have challenges with integrating the telehealth with their their other visits, and how do you really make that work. So I think you talked about some really great things today. So we will post the slides online. Happy to entertain any questions again. And thanks to everyone for being here today. Thank you.
Thank you.
Thank you.